Greetings, I'm Dr. Peter Noseworthy, an electrophysiologist at Mayo Clinic in Rochester, Minnesota. During today's commentary, we'll be discussing the recently released ACC-AHA Syncope guidelines. I'm joined by my colleague, Dr. Win Shen, who's the lead author of these guidelines and the chair of the Division of Cardiovascular Diseases at Mayo Clinic in Arizona. Welcome, Win.
Thank you so much, Peter.
First off, congratulations on these guidelines. I know your team has put a lot of work into this, and speaking as a clinician, I know we're all going to be very happy to have some guidance on the issue.
Yes, thank you. It really took a real teamwork for 2 years before we got to this point.
Right, yeah, I'm aware. Now, syncope is so common. 40% of us will have syncope at some point in our lives. And I was actually surprised to see that these were the first formal guidelines from the AHA and ACC regarding syncope. Why do you think they were so long in coming?
That's a great question, and I can only give you from my perspective. Syncope is so common, and it is a symptom, so it really can be associated with so many conditions. And so if looking in the past, you see that there were reviews and summary and statements that from different societies. And from American Heart ACC and Heart Rhythm Society, about 10 years ago, there was a scientific statement on syncope, but with a focus on sudden death prevention. And so when the syncope proposal was put forth to the task force, the guideline task force at ACC and AHA, that was immediately recognized that we should provide a more comprehensive recommendation for this very diverse group of patient population. And so this was commissioned about 2 to 3 years ago when we started working on this paper. Yeah.
I see. Syncope, of course, is a very broad topic. So what were your overall goals of these guidelines?
There were several. The first goal is really to set the standard definition for syncope and many other associated conditions. The reason why that is so important is because if you look into the current papers and studies, and sometimes the definitions for different conditions vary quite a bit. So that was the very first goal. And second goal, of course, is to recommend and set the standard practice for a large body of physicians, healthcare providers, for cardiologists, electrophysiologists, internists and neurologists, emergency room physicians, and in this document we also included the pediatric population. So that's the second kind of broad scope as well as the goals. And then third is really to identify some of the areas that we are in need of additional data and then facilitate future clinical studies. So these are the three main goals.
Great. So getting to the meat of the guidelines, let's start with making a diagnosis. I think one of the challenges in syncope is knowing how much testing to do. We all try to avoid unnecessary testing. Can you tell me what is essential for everyone, in the workup for everyone with syncope?
Well, what you will see that the writing committee really came to a consensus, really uniformly recommending that a detailed history and examination for the initial evaluation is obligatory. And second is that after lots of debate and deliberation, we recognize that even though the diagnostic value of ECG is really at a low yield, but it does carry a significant prognostic value. So we also recommended ECG as part of the initial evaluation. And it is absolutely correct that in this guideline you will see that we recommend not to do a broad diagnostic testing and broad testing for blood test imaging modalities.
Okay, so for patients with clear-cut vasovagal syncope, the history and physical and an ECG is sufficient?
That is correct.
Are there any tests that are not recommended, the Class 3 recommendations, for instance?
There are several Class 3 recommendations, but perhaps that I should qualify what I'm going to say by saying that the clinical judgment and what you will see in the guidelines that we frequently invoke the phrase in selected patient population. So for instance, we made a recommendation not to do blood testing in patients presenting with simple and vasovagal syncope. But on the other hand, if a person comes in with chest pain, of course, that additional blood testing that should be considered. And the other areas that we made class 3 recommendations would be imaging. For instance, we do not recommend broad scope cardiac imaging, CT, MRI, that for patients with a normal ECG without a prior history of heart disease. And we also recommend not to do broad neurological imaging like carotid ultrasound, CT scan, and MRI scan of the head and neck.
Okay. In the emergency department, a common challenge is who should be admitted to the hospital. Do the guidelines give any recommendations regarding
Yes.
this?
In this guideline, we made a very clear recommendation with a summary table as we put in as the serious medical conditions. If a patient presents with a list, any or more than one of the conditions that belong to the serious medical conditions, and admission to the hospital, that would be recommended. And these are actually fairly intuitive. For instance, a patient presented with syncope, with ventricular tachycardia, a patient presented syncope, although that the etiology has not been confirmed, but with serious head trauma. And these are the conditions that should be considered, the admission for evaluation should be considered.
Okay. As an electrophysiologist, I find that we're doing fewer and fewer EP studies, but there's still probably a role for a EP study in selected patients. Can you expand on that?
Yes. EP study, as we know, that 20, 30 years ago really was viewed as the court of the final appeal, that for syncope evaluation. Through the years that we learned the value of the EP study, that perhaps the sensitivity and specificity vary depending on different conditions. And number two reason why that the EP study that has decreased through the years is because, as we know, patients with structural heart disease, with non-ischemic cardiomyopathy, with reduced ejection fraction less than 35%, and with or without syncope, these patients qualified for an ICD. And then furthermore, that we have so many different monitoring devices today that allowing us to monitor these intermittent episodes. As a result, the value of the EP study has diminished, but in patients that after myocardial infarction and with a preserved ejection fraction and say 45%, and these are the patients EP study that can be useful.
Similarly for tilt table testing, although we still do tilt table testing at Mayo Clinic, and I know other centers do, some have entirely abandoned the process and or the test altogether. What are the recommendations for tilt table testing?
Most times, the diagnosis of vasovagal syncope can be made after a thorough initial evaluation with a history and physical examination. In patients when the recurrent episodes are not very well defined, or when the presentation is not typical of vasovagal syncope, this is the time that the tilt table testing that can be useful.
Okay. Well, moving on to management. The management of recurrent vasovagal syncope, I think, is a major challenge for cardiologists. And the various therapies, beta blockers, Florinef, Midodrine, SSRIs, pacemakers, compression stockings, salt tablets, and so on, have all really had limited benefit. What are the evidence-based recommendations for management of recurrent vasovagal or neurocardiogenic syncope?
Well, as you already mentioned, these pharmacological interventions, and when we reviewed the evidence, and sure, there are some clinical trials, lots of observational studies, but if we combine that the scope, the quantity and quality of the data, most of these recommendations for pharmacological therapy actually became a class 2B. We made one that class 1 recommendation, but based upon expert opinions, and that is to educate the patient to make sure they understand vasovagal syncope overall is a benign condition, and if they really could prevent triggers, and also that paying attention to the initiating prodromes, and a lot of times vasovagal syncope could be prevented.
Okay, great. Should any of these patients receive a pacemaker?
Yes. Lots of studies have been performed, randomized trials, double-blinded and not double-blinded studies. And as a matter of fact, this was the question we put forth to the Evidence Review Committee, and you were a member of the writing committee on the evidence review. We really asked the Evidence Review Committee to, in a very thorough manner, and did extensive literature search. And we specified the studies and the types of studies, the duration of the study, inclusion, exclusion criteria, meet the criteria to be analyzed that in the meta-analysis. After this process, that the writing committee of the guidelines really that were very, when it comes to the final decision of making a recommendation of pacemakers, that we made the pacemaker to be a Class 2B recommendation in patients who are older than age 40, that with recurrent vasovagal syncope with documented spontaneous pauses.
Okay, and what qualifies as a significant pause for pacemaker implantation?
We followed the exact definition from the clinical trials, and that is, and when a pause is documented associated with symptoms of syncope, and that pause is defined as greater than or equal to 3 seconds. In a person without syncope, when a pause is documented to be 6 seconds or longer, and those two situations would qualify to be qualified as a pause, and the pacemaker could be considered that in patients with recurrent syncope and older than age 40.
Okay, great. Another thing that comes up a lot in practice is driving. Do these guidelines make recommendations about driving after syncope?
This was a very, very important topic, but at the same time was very challenging. The writing committee discussed, deliberated, and reviewed extensively of the evidence. And we really couldn't reach to the level of consensus of recommendations. After discussion with the task force committee, with the chair of the task force, what we did was that and then after reviewing all of the evidences, what we did was the following. One is that we made one recommendation, and that is that physicians and healthcare providers that should be familiar with both local and the federal laws about driving with syncope, after syncope. Number two is that when it comes to commercial driving, we recognize that it is really not the healthcare providers that making the recommendations about commercial drivers. It is the Department of Transportation that who have strict guidelines about whether commercial drivers could drive or not to drive. So we defer that to really the federal law from the Department of Transportation. When it comes to private driving, what the writing committee we did was that we made a summary of a table of all of the conditions, and what we did was to suggest that an observational period that without recurrent syncope, and then the patients that would be allowed to resume driving. So there was no formal recommendation for private driving, but we did make suggestions with a summary table.
Okay, thank you. That's very useful. So I would like to thank Dr. Shen for joining us today to review the new ACC-AHA syncope guidelines, and thank you for joining us on the Heart.org and Medscape.